Hello, fellow SOTAs, practitioners, and professors. My name is Mike Dickreed, and I'm a second year student in the Occupational Therapy Assistant Program here at Owens. Now, today I would like to talk to you all about somatosensory aspects of recovery in patients who have suffered a cerebrovascular accident or stroke. Now, somatosensory aspects of stroke recovery refer to pain, pressure, proprioception, vibration, temperature, things like that. Now, the article that I researched, which I found on the CINAHL database, focused on these aspects because they felt that it was a tad overlooked compared to quote unquote traditional stroke recovery, such as strength, range of motion, things like that. Now, throughout most of my field work, my level 1s and level 2, I have worked with a variety of patients who have suffered a stroke. Some patients more high functioning than others. The intervention that I utilized is something that I learned about in my first level 2, my first full-time field work. And this intervention is typically used on patients who are a little more quote-unquote low functioning. It's called a tilt table. Tilt table is exactly what it sounds like. It's a big table. You slide the patient over. It's a dependent transfer, a lateral dependent transfer onto the table utilizing the bed sheet. Definitely a two-person job at least. And the patient is on the table. They are strapped in with 3 large Velcro straps, and it is raised ever so slightly using a remote control. The straps, one goes under the axilla, one goes across the abdomen. Unless an ostomy bag is present, then they would go over the thighs, and then the last strap would go over the shins to ensure patient safety. Also, placing a pillow behind the patient's head is not a bad idea either. Now, when I was at this site, typically we would raise the patient every 10 degrees to see what they can tolerate. If you raise them too quickly, they could get dizzy. If they're in bed for too long, they can get scared. So it's wise to take these things slowly, or as much as they can tolerate. Now, 2 obtainable goals for this treatment, I believe, would be appropriate. Number 1, the patient will tolerate at least 5 minutes on the tilt table at greater than or equal to 30 degrees before the end of the treatment session. And number 2, patient will successfully weight shift from one leg to the other 10 times with mod assist before the end of the treatment session. Now, those are some things that you can work on while you're on the tilt table. You can focus on weight shifting, getting that pressure in those joints in the lower extremities to simulate standing, because a lot of the patients that I saw at this site were walking was not in the cards. Now, one frame of reference relative to this treatment session, I believe, would be the biomechanical frame of reference, which focuses on impairments that may be amenable to remediation. And with patients who have suffered a stroke, recovery is different for everybody, but I think that using the tilt table is a stepping stone towards standing and standing to walking. Now, this intervention can be classified into 2 types: preparatory tasks and education. The patient and practitioner are both responsible for making sure there are no wires or tubes or anything that can get caught while the transfer is taking place, which could lead to lines getting pulled out of the skin or something getting knocked over. It's not a good thing. It is, as I stated before, it is recommended that more than one person should help with the transfer to ensure patient safety. Now, once the patient is on the table, the practitioner can provide education to the patient, what to work on to benefit them, such as stated before, weight shifting onto each leg to get that pressure in the joints, or reminding the patient of the benefits of simulating standing upright to improve proprioceptive awareness. Now, this intervention can help muscle degradation from remaining in bed and also create opportunities for other treatments while standing upright, such as upper extremity exercise with a TheraBand or focusing on ADL such as hairbrushing. Some of the programming outcomes to enhance the treatment goals previously stated would be to improve lower extremity function for ADL, IADL tasks, and quality of life, working to get back to standing and possibly walking, or with adaptive equipment. Thank you all for listening. This concludes my presentation. If you have any questions, I'd be more than happy to do my best to answer them. Thank you so much. Have a good day and wash your hands.